and share experiences to do with burns in nursing. And this is our fourth presentation in the series of related subject areas where we are keeping nurses in the loop regarding trends in nursing care of patients in the emergency departments. And I'm quite happy to present after Emmanuel, who came through with the first webinar on trauma in nursing. And you find burn injuries are traumatic as well. They are a type of traumatic injuries. I'm also happy that Emmanuel already introduced the ABCs that we are going to be touching on during this presentation. And Petra presented our second webinar where she was talking about why engage families in the care of patients in the emergency departments. And it's quite an important area because patients with burn injuries as well, they come in with family members who are quite distressed. And sometimes we do forget to involve them in the care. We sometimes don't plan to engage them during that crucial stage because we are so busy with trying to resuscitate the patient. And I'm so happy that Mahlomola also touched on fluid resuscitation, and burn injuries are a type of injury that will result in shock, fluid volume deficits, fluid shifts, and we already have had some information from our third webinar about the types of fluids that are used in fluid resuscitation. So it is actually my pleasure to be presenting to you this afternoon after the three important topics that actually feed into today's presentation. If you don't mind, I'm going to just switch off the video and then I will present using the audio only. I am an emergency care nurse and a lecturer at the University of Zimbabwe in the nursing science unit. I have already put my email address in case you want to email me, and I would like to make this presentation very interactive and we'll have discussions. Feel free to chat in the chat box. I'll be able to read the chats later, ask questions, and we'll try and interact as much as possible. I am going to try and fulfill 5 learning outcomes for this afternoon. Of course, we are going to do a lot of revision. Burns in nursing is not a new topic. There is a lot that we already know. We are just going to be introducing new concepts here and there, but by and large, we are actually going to be talking about things that are familiar. So the main things, learning outcomes that we have are that they are some capillary responses that occur following a burn injury. And while we are discussing, let's just reflect on explaining the capillary responses to burn injury that lead to capillary leak syndrome, and the expected physiologic reactions to the autonomic compensatory responses in the early phase of a major burn injury. And I think those two are of utmost importance because they help us to prioritize our nursing interventions. And particularly, I will zero on the emergent phase of a burn injury. And we also know that burn injuries are a type of condition that requires a long period of therapy, but I will zero my discussion on just the emergent phase of a burn injury. And because in the emergency rooms, we are really dealing with that phase mainly. And then the fourth learning outcome is for us to be able to determine the effectiveness of fluid resuscitation during the emergent phase of burn injury. And we know we do have a lot of challenges from the various environments that we are coming from, and we would like, as our last learning outcome, to discuss the major challenges in managing burns during the emergent phase. And I hope we will have a good discussion about the major challenges. So the first slides are just a reminder, and if I'm going too fast, the assumption is that a lot of those things are just reminders, and we already know a lot about them. And the way I am going to proceed with the presentation is we'll follow this outcome, the outline, just a brief on the incidence of burns, prerequisite knowledge, definitions, types of burn injuries, classification of burn injuries, phases of burn injury management, and those phases are going to lead us to just zero on the emergent phase, and we discuss the major challenges that we meet. And I think burn injuries are a commonplace in a lot of areas, and they are one of the major causes of visits to the emergency rooms and subsequent hospital admissions. We get quite a number of deaths emanating from burn injuries annually. You find that WHO in 2018 estimated that 180,000 deaths occur every year, and they are caused by burns. And the vast majority occur in our environments in the low and middle income countries. And in 2019, you can see this mortality going up, actually. At least 200,000 deaths annually were reported by Lin et al. So you find burn injuries are a major traumatic condition that we need to be well versed with. And the prerequisite knowledge that we just remind ourselves about when dealing with burns is we need to know the anatomy of the skin, from the epidermis right through to the dermis and the subcutaneous tissue before you get to the fascia and the muscles, and below the muscles there is the bone. So the skin actually ends at the subcutaneous tissue. It's comprised of the epidermis and the dermis, and these layers are important because we use them to classify the depth of the injury when we are assessing the patients. And it's just a good reminder: anatomy of the skin, physiology of the skin, particularly to do with alterations in normal skin function related to burn injuries. We need to have prior knowledge that the skin is a protective barrier, and burn injuries cause us to lose the protective barriers. We have body fluid shifting, particularly into the subcutaneous tissue, and patients with burn injuries end up being very edematous. And the skin helps us in temperature control, and a patient who has had burn injuries, particularly if they are extensive, will lose that ability to control their temperature. And this is why in the management, we need to be warming them later on after the initial first aid practices of cooling the burnt area. We need to warm the patients using various warming methods. And you find that the sweat glands and the sebaceous glands, which are within the skin, get destroyed. And so we lose quite a bit of function there on the skin. And the number of sensory receptors are diminished following burn injuries. And these are important points to bear in mind, that patients may lose their sensation. And the severity of these alterations really depends on the extent of the burn and the depth of the damage. And when we lose our sensory receptors, you find that some superficial burns are very painful, and other deeper ones may actually be painless, and the patients might not feel any sensations at all. So those are the prerequisite knowledge bases that we need to have. And I think burn injuries are not something that we can spend time defining, but just to remind each other that we are talking of destruction of the skin or body tissues by exogenous heat. And it is usually excessive heat that causes that damage to the skin. And some definitions would say it's a coagulative necrosis of tissue due to excessive exogenous heat. And actually, the last definition of coagulative necrosis, it actually is a definition that brings us to the pathologic features of a burn injury. And you find that in 1947, Jackson devised or came up with a theory, a burn wound model, Jackson's theory, which actually stipulates that when a burn injury occurs, there is a central zone of coagulation. And this is a zone where you find necrotic tissue, and the cells in that zone are actually dead. So there is coagulation in that superficial central part of a burn injury. And then the zone of coagulation is surrounded by a zone of stasis, followed by a zone of hyperemia. And the zone of stasis is actually a zone that is crucial, because when we are resuscitating, fluids, giving fluid therapy and managing this patient, we are really wanting to target the zone of stasis, because our interventions will tell whether the zone of stasis is going to enlarge the coagulation zone or recover and give us a better outlook. And so our resuscitation methods are really targeted on the zone of stasis. It has got potentially viable tissues, which, if we do the correct things, they can actually be preserved. And so that definition is very important. It gives us bearing on Jackson's burn wound model. And the third zone, which is called the zone of hyperemia, it actually surrounds the zone of stasis, and it's an area of increased capillary membrane permeability. It's the outermost zone, and the tissue perfusion in that zone is increased, and the tissues in that zone will invariably recover unless there is severe sepsis or prolonged hypoperfusion. But one thing that is happening in that zone is that it's hyperemic because there is increased capillary membrane permeability. Normal capillaries normally don't allow protein molecules, large molecules, to move out of the intravascular compartment. But capillaries in that zone of hyperemia, they leak out, and protein molecules will move into the interstitial spaces, and that will worsen the edema because colloid osmotic pressure is going to increase in the subcutaneous tissues, and we actually find fluid shifts getting worse and worse. And so the definition of definitions that are available for burn injuries actually give us that background of some of the things that will be happening in burn injuries. The types of burn injuries can be subdivided into many subtypes based on the causes. We do have thermal injuries, and under thermal injuries, we have scalds, we have flash burns, we have contact burns, we have flame burns, and electrical injuries, chemical injuries. And although we have defined burn injuries as being caused by exposure to excessive heat, you find that we have another type of burn injuries that is caused by excessive cold, like the frost bites. And then we have troublesome inhalation burns that come about because of pulmonary exposure to a wide range of chemicals in various forms, and radiation burns. So we have quite a number of subtypes of burn injuries. However, whatever subtype you are looking at, burn injuries are classified for the purposes of therapy, for the purposes of assessment. We have various classification systems that are used to classify burn injuries. And the first one is that they are classified according to the size of injury in terms of the total body surface area. And when we are talking about the management of burn injuries, the first phase in our nursing management is the assessment phase, and we need to assess the size of the burn injury. And we do have quite a number of strategies for assessing the size. We do have the Wallace's rule of nines, the Land and Browder chart, which is actually our standardized age-based assessment, and it's actually the gold standard in terms of accuracy. And then we have the PALM method. And we can also classify burns according to the depth of injury. And in this classification system, we can classify the burn injuries according to degrees or according to the thickness of skin involvement. So we have first degree burns, second degree, third degree burns, and the fourth degree burns, which are quite deep. And we can also classify depth of injury according to the thickness of the skin that is lost. Partial thickness can actually be subdivided into various other ways: superficial, partial thickness, deep partial thickness, and so forth, or full thickness according to the depth of injury. And then we do have another classification system which classifies burn injuries according to the severity of injury. We can have burn injuries being termed minor, particularly those of less than 10% body surface area in adults. And in young children, we are looking at less than 5%. But if they become full thickness burns, you find less than 2% will be termed minor. And then we have other classifications that will divide burn injuries into moderate burns and major burns, which are quite severe. And we have various strategies of classifying burn injuries according to severity. And major burn injuries are usually above 20% of the total body surface area burnt in adults, over 10% total body surface area burnt in young children, above 5% if it's full thickness burns, and any burn injuries involving inhalation injuries, they are so significant. These burns to the face, eyes, ears, they become major burns because of the location. And also burns that are associated with significant pre-existing conditions, like burns occurring in diabetic patients, burns associated with fractures, they become major burn injuries. So the classification systems are just a reminder. And so when we are managing burn injuries, you find that there are three phases that we particularly pay attention to. The first phase of burn management is called the emergent phase. And the emergent phase includes pre-hospital and emergency room care. We know that our patients, when they come to the emergency rooms, there is some kind of first aid that will have happened at the site of injury, be it a home environment, be it an industrial area. And The pre-hospital phase is a whole chapter on its own. We are not going to go deeper into it, but we know there are a lot of first aid strategies that are done in our communities. Some of them are good, some of them are detrimental. And we just need to bear this in mind so that as we receive our patients, we can actually tell that sometimes a first degree burn, it gets to the emergency room getting deeper now because of some of the strategies that are used in the pre-hospital environment. And the emergent phase is quite an important phase for us. It's the phase that we are mainly going to be concerned about because we deal with these injuries in the emergency room in the first 48 to 72 hours. And we are in the emergent phase. And the primary goal in the emergent phase is to prevent hypovolemic shock, preserve vital organ function, and treat life-threatening airway breathing issues. And it's the phase where our patient will be in the oliguric phase. And the acute phase that follows is a restoration phase, is the phase that the patient can actually get into the burns unit for admission during that acute phase. And then the rehabilitation phase is the final phase of burns care. It goes beyond hospitalization and it focuses on enabling clients to gain independence and achieve maximum function. But I've put red asterisks there on the emergent phase because that's what we are going to be talking about more than the other two phases. And for us to understand the management during the emergent phase, we need to have an overview of the pathophysiological mechanisms during the emergent phase, because some of our strategies, nursing strategies, they are thoughtfully done in view of knowledge of the pathophysiology that has happened during a burn injury. And you find that there are various diagrams that postulate the numerous mechanisms that are happening behind the scenes. When you get a burn injury, whatever the cause may be, that thermal injury is going to lead to quite a number of things. Just from where we talk about the burn here, that's the thermal injury, we get cells breaking down, tissues breaking down, and cells, if they are muscle cells, if the burn is that deep, they release myoglobin, and myoglobin will have problems, will create problems for us as there will be renal involvement and clogging of our nephrons because of myoglobin. And so that thermal injury alone can lead to myoglobin release, increase in metabolic needs because of the tissue injury, and the cells that are breaking down are going to release a lot of intracellular potassium. And a patient with burn injuries is going to have hyperkalemia. And there is loss of red cell mass because the blood vessels will be destroyed and patients eventually will have anemia. And that thermal injury is going to cause a lot of inflammation, fluid extravasation, the increased capillary membrane permeabilities. And sometimes when we talk of the inflammatory mediators that are released by the cells, the injured cells, the mast cells, you find the inflammatory mediators are so many. Each one of them will have effects on our body systems. If you look at the tumor necrosis factor, the interleukins, the histamine, bradykinins, serotonins, prostaglandins, they are meant to mount an inflammatory response, but sometimes it is a source of a lot of the problems that we see with fluid shifts, because there will be increased capillary membrane permeability, fluid extravasation, fluid leakages, and so forth. And you find that we also have we do have the myocardial depressant factor, which has a lot of issues on the heart. We are going to go through these pathophysiologic mechanisms. As you will see, the extracellular fluid shifting and hemoconcentration and having a lot of hemodynamic changes leading to hypovolemic shock, and which we call Benz shock. So the goal here is to restore tissue perfusion. Just one moment for me. I'm just going.
Hello there, Rudo. Are we on track?
I'm sorry about the hiccup. Sorry about the hiccup. There was an emergency this side. Somebody just rushed into the room because there's a student who has collapsed. I'm really sorry about this, but I think we have managed to fix it. Somebody has taken over. So we're talking about the pathophysiological mechanisms that we do encounter following burn injuries, and these do give us a lot of bearing on our management in the emergent phase. And I would like to proceed to the next slide, which will make us see that besides the hypovolemic shock, the Benz shock, besides the organ failure that occurs, we see quite a multitude of autonomic responses to the physiologic mechanisms that will be going on. Our patient, from this diagram, you can see they experience a lot of thirst. They are having respirations that are rapid and shallow. Whether there is inhalation injury or not, somebody who is in a state of shock will exhibit these signs. And there is shunting of fluid from the vital organs. And so there is going to be sluggish motility in our gastrointestinal tract. And this can actually cause some ulcerations we have Curling's ulcer forming, and there is a bearing in our management that we need to remember this. And we also have patients having paralytic ileus because of the slow gastric motility. And this is why in the emergent phase, our patients need not be fed. They need to have a nasogastric tube for continuous drainage. And sympathetic response, shocked states, they increase catecholamine secretions from our adrenal glands, and that is going to increase metabolic rate, caloric needs, and fluid will be shifting into the intravascular, from the intravascular compartment into the interstitial spaces, and that causes generalized edema, weight gain, and there is a tachycardia. The liver is going to increase its their activities, and blood sugar is elevated. We have quite a lot of problems which will touch even on the urinary system. Oliguria, increased specific gravity, and our ulcerations in the GIT can actually give us some hem occult positive stools. And so all these physiologic mechanisms actually lead us to a syndrome which is called a Berne syndrome. And a Berne syndrome is associated with fluid and electrolyte imbalance, metabolic disturbances, bacterial contamination of tissues, vital organ complications. And if we look at each one of these, starting with fluid and electrolyte balance, the Berne wound becomes rapidly edematous, and we are going to lose a lot of water, sodium, albumin, red blood cells, and we'll have the hyperkalemia that I've talked about. And unless intravascular volume is rapidly restored, shock develops. And metabolic disturbances are going to be there, hypermetabolism. There is going to be bacterial contamination of tissues, and we actually see immunologic reactions happening during our Berne injury sequelae. And vital organ complications will touch from renal insufficiency, pulmonary dysfunction, gastrointestinal complications, and if nothing is done in good time, there will be multi-system organ failure. And so with this in mind, we know that Berne injury management is a type of management that requires us to use the trauma life support skills, and our approach is best when done systematically, and we need good management to prevent morbidity and mortality. And our ABCs actually do play a good role as a strategy to manage our patients in this emergent phase. Airway control is of utmost importance. Our patients sometimes do have inhalation burns, and that type of burn requires urgent management. So airway control, breathing and ventilation, circulation, and we also need to assess for disability, environmental control for temperature control, and fluid resuscitation. And in each of those areas that I have mentioned, we actually need to pay particular attention for inhalation, for our airway management. Facial burns are so notorious. Sometimes if flames were involved, inhalation burns are inevitable sometimes. And breathing, we better be aware of carbon monoxide poisoning. The patient may appear pink with a normal pulse oximeter reading, but if there is an element of carbon monoxide, we need to move fast and just make sure we treat for that as well. And for circulation, we need to bear in mind that there is fluid loss from a burn, and this fluid loss is quite significant as to cause shock. And the next thing that I am going to touch on is for us to assess the extent of the burnt surface area. In our nursing management, assessment is after the ABCDs, we assess the burnt surface area. And we have 3 methods of assessment that we have talked about. And each one of those has their own pros and cons. And the first one we mentioned is the rule of 9. And it's a method whereby the body is divided or assigned percentages in multiples of 9. It is a very efficient method, but there is a danger of overestimation. Sometimes the rule of 9s does not work very well for children. And so there are advantages and disadvantages to that one. And the second method is the Land-Browder, which is a standardized age-based assessment. It's our gold standard. It can actually be, for people who are not used to it, it can actually be quite cumbersome to use. And the Palmer method, whereby the size of a patient's palm is viewed to be 1%. And this is another method that can be used to estimate the burnt surface area. And it's good for minor burn estimation, but there is a problem that there is user variability in using the Palmer method. And so these go without any explanations. Wallace rule of 9s, well known, but it gets adjusted in children because proportionally children have got the head surface area is proportionally bigger, and therefore there are some adjustments there. And then the Land-Browder charts need very little introduction. Okay, the Palmer method, very good for assessing small burns, and it's one strategy to remember. And then when we are managing for burn injuries, fluid resuscitation is the most crucial aspect of early care of the burns patient. And we need prompt initiation of fluid replacement. And we do have formulae that are so popular. They exist. The most widely used adult formulae are the Parkland formula and the modified Brook formula. And I think those formulas we all know about. And the important thing here is during this emergent phase, we are going to give crystalloids. Most protocols favor lactated ringers or ringers lactate, about 4 mils per kg per percentage burnt in 24 hours. And the important thing is we start to count the 24 hours from the time of burn injuries. We give in the first 8 hours, we give half that fluid, and then we divide the other remaining half of the fluid in the next sets of 8-hour periods. And all the time we monitor the urinary output, because this patient is going to be in the oliguric phase of the injury, and we monitor the urinary output. And a point of note is that there are some small differences for children. Parkland formula underestimates fluid needs, and there's great variability between surface area and weight in children. This is why we need to be very careful when dealing with fluid management or fluid replacement in children. Okay, and these fluid resuscitation formulae are only guidelines. We have to be monitoring patients' response to fluid. We do not over-resuscitate, and we use mainly crystalloids in the emergent phase, because colloids, remember, our capillaries are leaking, and if colloids leak into the interstitial spaces, they are going to cause a lot of fluid shifts because of a raised colloid osmotic pressure in the interstitium. And we monitor urine output. Just a reminder for adults, we aim at a minimum of 0.5 ml per kg body weight per hour as urine output. And children, because they don't concentrate urine that much, their normal urine output that we aim to achieve is 1 ml per kg body weight per hour. And while we are giving the fluid resuscitation, we monitor the pulse, the vital signs. Pulse pressure is more sensitive than blood pressure, and monitor the level of consciousness, capillary refill time, and we may even use invasive methods for monitoring the fluid status of the patient, and central venous pressure lines, Swan guns, catheters, just to help us monitor how well we are doing with fluid resuscitation. And although we are aware at the back of our minds that there is hypermetabolism, the principles of management are that in the emergent phase, we are not to start with nutrition. The patient should not be fed by mouth. They should have a nasogastric tube to drain the GIT. Remember, there is a risk of paralytic ileus, stasis of contents in the GIT, and the patient may even have abdominal distension. So we drain, but feeding has to be done as soon as the bowel sounds are heard, as soon as they come back. And so there is a bearing on hypermetabolism and the need for nutrition in that regard. So as we are aware of the fact that the hypermetabolic state is depleting our nutrients, we need to remember that the patient needs carbohydrates, they need proteins, they need fats, and enteral feeds are not the best, but if bowel sounds come back as soon as after 6 hours, enteral feeds can be given. But by and large, our carbohydrate requirements are going to come from the intravenous routes. It will be parenteral, and if need be, later on, we can even think of total parenteral nutrition. And in our management in this emergent phase, we need to remember that burns patients lose their thermoregulatory abilities. So we keep the temperature between 28 and 33 degrees Celsius, and warming of the patient is actually of utmost importance. Bacterial contamination. In the emergent phase, we know we try by all means to maintain our asepsis, clean linen, sterile linen, and avoid bacterial contamination as much as possible, because infections can actually give us problems in the post-recovery, in the acute phase after the emergent phase. You find burns usually get colonized by day 5 of post-trauma, and we need to make sure that we don't continue to cause infection on this broken skin, which was once upon a time a barrier preventing any microorganisms from entering the tissues. And so antibiotics are started early and the wound is covered appropriately. We do have protocols for burn management that we may have in our various environments. Anti-tetanus toxoid, for example, is part of our major protocols, because we know we need to prevent this patient from tetanus or preventable conditions. And while we are talking of infection, the anti-tetanus toxoid is not to be forgotten. I have actually deliberately left out some areas because I think they need our participation and discussion, because they come in the form of major challenges. I would like us to interact, and at this stage, talk about the major challenges in the management of burn injury patients from our experiences, particularly during the emergent phase. Let's talk about pain management first. It's something that I didn't touch on in terms of management. We know these patients are going to be in severe pain, and some of them might not feel the pain because of sensory nerve distraction. But if we are to give analgesia, it has to be adequate analgesia. So what are your experiences with pain management? The reason why I want us to discuss is there are various opinions. You find protocols will say give this patient some morphine for pain, and other areas will say morphine in the emergent phase is not a good drug because of the GIT involvement. There's sluggish peristalsis already, and morphine may worsen the scenario. Could we discuss pain management? What do you see as challenges, if they are there, in terms of pain management? And then we can move on to other challenges. I am going to open the floor to discussion. Anybody can actually go and discuss what they feel about pain management during the emergent phase. Thank you. I am not seeing any hands up, but anyone can unmute and talk. I have just cited pain management as one kind of challenge, but we have many more challenges. If anybody does have any challenges that the second one that I had for discussion is the one on family involvement and psychological support for the patient and the family. We have already been advised, we have already seen how important family is, but what challenges do we meet in the emergency rooms? So that if we are familiar with the challenges, we'll be able to plan. Can we share experiences on any of the challenges? Pain management is one, family involvement and psychosocial support is another. Anyone who would like to share experiences? Are we still there? Do I still have an audience?
Yes, you still have.
Oh, good. Thank you. At least you are there. I just wanted to make it interactive. Thomas, do you want to say something?
I don't know, but I'm not getting the question very clear. That's why probably I'm sure people are also not responding.
Oh, all right, Thomas.
Yeah.
We just want to discuss. We are saying we are zeroing on the emergent phase of burn management. And yeah, I have covered some of the management issues during the emergent phase. And I am saying we face quite a number of challenges in managing patients during the emergent phase. Some of the challenges are to do with pain management. And the question is inviting people to discuss any challenges that you may share at this stage to do with pain management, to do with family involvement, or any other challenges during the emergent phase.
Oh, okay. Now it's better. It's better. So
Thank
what
you.
I will talk about in our setting is that the challenge is multifactorial, but most prominent ones that is directly related to the patient care is the pain management. As you rightly made mention of, there's a lot of myth in relation to the analgesia. But what we normally do is we use the multinodular approach, where having any especially pain medication, so that at least one, because of cost element that comes into being, we are very careful not to start with medications that the costs are so high, for which when you put it on, you put it down, the relatives, patient's family cannot afford. And for that matter, the patient will be going through pain. We try just to count those that are available, we find order so that we optimize or we get the we use as man to ensure that patient can over here. The face the other is that as you really mentioned of the family support is also, and especially when it comes to getting some medication that needs to be given to them when we are not able to get all those things, especially the antibiotics, and even sometimes even things that we need to get in terms of even taking care of the patient banks daily. If you are not able to get that within this emergent phase, then the condition changes, and that is it becomes a headache, and management comes also high. So I think this is one that I want to share.
Thank you, Thomas. Thank you very much for sharing experiences in your area. And indeed, I thought those two would actually touch on a variety of issues, and they are experienced in many emergency room environments. Pain management, indeed. And I really like the way you have explained how you are approaching pain management in your areas when some people may actually forget because you really want to resuscitate this patient for shock. You forget that they are in pain. They may be unconscious, but they will be in pain. And some schools of thought would really want not to give the patient some narcotic analgesics because it may mask the diminishing level of consciousness. So the idea of choice of the medications for pain is of utmost importance, and you find most protocols, they do choose the drugs with that in mind. Thank you very much for sharing, Thomas. Anyone else who would like to share experiences to do with any challenges during the emergent phase for burn injured patients? If there are no further contributions, I would like to encourage you to think about the protocols that we have for burn injuries and see if we are saying everything is doable. We in our environments, we use protocols from books, protocols from charts, and we are supposed to follow them. A protocol is to be followed. Are we easily following them, or we are meeting some challenges? And if so, what can be done to improve burn management in the emergent phase? Thank you very much. I think with that in mind and with that discussion, I have come to the end of my presentation, and those are just some of the references that I used, and we can continue to discuss more challenges as they come, but I will open this time now for any comments or any questions. Thank you.
Thank you, Rudo. Whilst we wait for questions and comments from our participants, we also want to remind you of the upcoming AFEM conference in November. We want to encourage each and every one of you to register and be a part of the gathering of emergency medicine practitioners in Accra in November.
Oh, I'm just saying, thank you very much, Emmanuel. Thank you for the reminder. I am noticing on the chat section that two people mentioned that they were not hearing anything.
That was during the short break you had.
Oh, during that time. Okay, I'm sorry. I'm sorry about that. Really, that was very unfortunate. Somebody discovered where I was, and there was a student who had collapsed. So I just dashed out, and sorry about that. Oh, I thought the whole presentation was not audible. Thank you. So if we don't have any questions or comments, we can safely say this is the end of my presentation, and we can continue engaging each other, and we can put my email address there. We can continue discussing about this topic. We can also look forward to the next webinar, which is in line with the emergency room issues. Thank you. I think I'm done, Emmanuel.
Thank you very much for the wonderful presentation. We look forward to next month's presentation as well. On this note, until next month, same time, thank you all for attending, and we look forward to engaging you once again. Thank you.
Thank you. Yeah, the slides will be available. Definitely,
yes.
Somebody is saying, hope the
yes,
slides
so
will be
the
available.
slides will be uploaded on the AFEM website, as well as the video recordings as well.
Thank you.
Thank you. Bye, everyone.
Bye.